Today, we're tackling something intense. We're looking at one of the absolutely most aggressive, ultra-high-risk presentations in all of hematology, plasma cell leukemia, or PCL. Now, you know your standard plasma cell neoplasms, right? Well, this isn't that. This is an explosive leukemic presentation. We're talking massive numbers of circulating plasma cells, extensive marrow involvement, and a biology that literally demands immediate attention. If you're managing hematologic malignancies, mastering the diagnostic standards and the clinical framework for PCL isn't just helpful, it's absolutely essential.
Before we get into the weeds, I want you to just picture this for a second. What happens when a malignant plasma cell clone completely loses its dependence on the bone marrow? It breaks its cellular tethers and just escapes straight into the circulating blood. That single biological crisis is the defining feature of plasma cell leukemia. And it fundamentally changes everything: how the disease presents, how we diagnose it, and the sheer absolute urgency with which we have to treat the patient.
Okay, Section 1, Redefining Plasma Cell Leukemia. Let's dive right in.
Notice the really dramatic drop in the diagnostic threshold here. So historically, to diagnose PCL, we actually required at least 20% circulating plasma cells on a smear, or an absolute count of 2 × 10⁹ per liter. But the revised IMWG definition for primary PCL, it brings that threshold all the way down to just 5%. So why the massive change? Well, extensive validation studies proved that patients sitting in that 5 to 19% range had the exact same adverse, ultra-high-risk clinical outcomes as the patients hitting the old 20% mark. Basically, even a small percentage of circulating clones changes the game. It means a massive difference in clinical urgency.
Moving to Section 2, Escaping the bone marrow.
So how exactly does this escape happen? The biological sequence is actually pretty striking. Normally, plasma cells are strictly anchored down in their bone marrow niches, but in PCL, it all kicks off with a high-risk post-germinal center clone. This clone basically rewrites its own surface profile, causing a profound loss of marrow adhesion. This is what lets it escape into the peripheral blood. From there, it survives and rapidly seeds widespread extramedullary infiltration, meaning it floods into organs and tissues totally outside the marrow, setting off rapid systemic tumor growth.
Let's zoom in on the exact molecular mechanics of this escape. The critical failure here is that severed tether to the marrow environment. You'll see a reduced expression of CD56 and deeply altered CXCR4/CXCL12 signaling. What that does is effectively cut the cell's connection to the marrow stroma and the extracellular matrix. Now add in some high-risk secondary genomic abnormalities driving proliferation, and what do you get? A clone that is fully equipped to survive completely independently in the bloodstream and aggressively invade distant tissues.
All right, Section 3, Clinical Presentation and Morphology.
When these runaway cells flood the system, the clinical presentation is starkly different from your conventional multiple myeloma. In ordinary myeloma, we're often looking for those classical punched-out skeletal lesions. But in PCL, because the clone is actively circulating, we see massive, severe organomegaly. It infiltrates the liver, the spleen, the lymph nodes. Patients suffer from profound cytopenias, thrombocytopenia in particular, because of the rapid marrow replacement. We're also frequently dealing with extramedullary soft tissue masses, central nervous system involvement, and an unbelievably aggressive lab profile, featuring sky-high LDH and beta-2 microglobulin.
Let's look closely at the actual peripheral blood morphology on these ultra-crisp smears. Now, sure, you might see some mature plasma cells that still hold on to that classic eccentric nucleus and perinuclear HOF, but pay very, very close attention to the plasmablasts. Look at that high nuclear to cytoplasmic ratio, the prominent central nucleoli, the frequent mitotic figures. When you spot this plasmablastic morphology, it is a massive red flag. It literally equals highly aggressive, rapidly proliferating disease.
Now for Section 4, Advanced Diagnostics and Differentials.
Flow cytometry is absolutely essential here. It's a total game changer. When we look at the distinct clonal clustering on these scatter plots, the plasma cells typically light up positive for CD38, CD138, and MUM1, showing clear cytoplasmic light chain restriction. But honestly, what's truly fascinating is what is negative or reduced. They completely lack CD19 and CD45, and crucially, they show reduced or completely absent CD56. Like we talked about with the molecular pathogenesis, that loss of CD56 perfectly supports this neoplastic circulating phenotype. It's the smoking gun that confirms they've shed their marrow anchors.
Alongside flow cytometry, cytogenetics completely drive our understanding of the risk here.
PCL is heavily enriched for high-risk genomic abnormalities. FISH testing routinely reveals classical adverse lesions. We're talking deletion 17p, TP53 mutations, 1q gain. But there is a really vital therapeutic target hidden in the genetics, the translocation T1114. While PCL is overwhelmingly high risk, this specific T1114 translocation creates a unique biological dependence on BCL2. And that potentially opens a highly specific therapeutic window for targeted therapies, like venetoclax, in carefully selected patients.
Okay, a quick but crucial reality check. Just because you see plasma cells in the blood doesn't automatically mean it's leukemia. We have to quickly and clearly differentiate true primary PCL from reactive plasmacytosis. Say a patient has severe sepsis, a massive autoimmune flare, or a major viral infection. They can totally have a transient wave of plasma cells. But those reactive cells, they'll be polyclonal, they're usually CD19 positive, and they are tied to a specific inflammatory event. True PCL is clonal, it's CD19 negative, it is a true malignancy, and it persists. Flow cytometry makes this distinction crystal clear for us.
Then there's the distinction between primary and secondary PCL, where the timing and the biology are vastly different. Primary PCL is de novo. It happens right at the initial diagnosis, and while it's incredibly aggressive, it is a previously untreated clone. Secondary PCL, on the other hand, is the terminal leukemic evolution of known, previously treated advanced multiple myeloma. Because that secondary clone has already been heavily selected by prior lines of therapy, it is highly multi-drug resistant. Consequently, secondary PCL carries an extremely poor prognosis, whereas outcomes for primary PCL are slowly but steadily improving with modern therapies.
Which brings us to Section 5, Emergency Management and Treatment.
I want you to read this quote and really take it to heart. Plasma cell leukemia is a medical emergency. Patients face immediate, potentially lethal threats the minute they present. We are talking about acute renal failure, life-threatening hypercalcemia, massive bleeding from thrombocytopenia, and tumor lysis syndrome driven by this unbelievably high tumor burden and proliferation rate. You simply cannot wait. Rapid, aggressive disease control is your #1 objective. So to achieve that immediate control, we deploy a rapid induction therapy algorithm. Now, there isn't one single universally established randomized standard out there, but the consensus is completely clear. You urgently start a highly active multi-drug regimen. You're combining an anti-CD38 monoclonal antibody like daratumumab, a proteasome inhibitor like bortezomib, an immunomodulatory drug like lenalidomide, and dexamethasone. You have to hit this clone simultaneously from multiple mechanistic angles to just halt its progression in its tracks. Once you actually get that disease control in a fit responder, we move aggressively to early autologous stem cell transplantation. However, and this is a huge point, the transplant alone is not enough. While it does significantly deepen the response, PCL has a notoriously high risk of early relapse. Therefore, that transplant absolutely must be followed immediately by intense multi-drug consolidation and then continuous aggressive multi-drug maintenance. Standard single-agent maintenance simply isn't going to hold back a clone this aggressive.
But what about patients who do relapse, or those presenting with secondary PCL? This is where we rely heavily on the absolute cutting edge of immunotherapy. Modern cellular therapies like BCMA or GPRC5D-directed CAR T cells and bispecific antibodies are absolutely crucial for managing this refractory disease. We also leverage venetoclax for those selected T1114 cases we identified earlier. And for sure, we should always be evaluating these ultra-high-risk patients for clinical trials right from the start. Finally, Section 6, Prognosis and Minimal Residual Disease.
Minimal residual disease, or MRD testing, is vital. But I have to give you a massive warning here. A marrow-only MRD test is completely insufficient in PCL. Because this disease actively circulates in the blood and forms extramedullary masses, a clean marrow biopsy might totally miss residual disease hiding somewhere else. You absolutely must integrate next-generation flow or sequencing of the marrow with peripheral blood assessments and PET-CT imaging to confidently call a patient truly MRD negative. Even with our absolute best, most modern multi-drug combinations, we still have to be hyper-vigilant about these adverse prognostic features. Patients with secondary PCL, those showing that plasmablastic morphology on their smear, high-risk genetics like deletion 17p, extramedullary or CNS involvement, or frankly those who just fail to achieve rapid MRD negativity, they face severe complications to their survival. These adverse prognostic features explain exactly why aggressive, continuous, multi-drug treatment is absolutely mandatory from day one.
So this leaves us at a pretty fascinating frontier. We've seen exactly how this high-risk clone breaks its tethers, escapes the marrow, wreaks systemic havoc through the blood, and how incredibly intensely we have to treat just to regain control. But with the amazing horizons of CAR T-cell therapy and bispecific antibodies aggressively targeting these specific cellular markers, can we finally trap the escaped clone for good? It's a question that is literally defining the next era of hematology research.